Thanks, Rich, for that incredible introduction. I hope I can live up to that. I'm going to share my screen. While I'm doing that, I want to just say that I agree it is a shame that I can't spend some time with the residents today, and I hope to be able to do that in the future. But in the meantime, I would be delighted to talk with anybody who's thinking about kind of that transition out of residency and into a research career, clinical or translational research career, and how to think about that jump into more training versus clinical practice and concurrent research. So, but today, I am really delighted to be here and grateful for the invitation to speak with you all today. And I want to speak today about kind of a big and unwieldy problem in a common but overlooked disease. And I want to spend the majority of our time today talking about how we can wrap our arms around this problem. And that problem is, of course, HS. My conflicts of interest are listed here on the bottom of the slide. And today, we're going to start with some background about HS to make sure that we're all on the same page. And then I'm going to go on to provide some context about the scope of the problem that we're facing with HS. And then I want to spend the majority of our time today discussing what we've learned about HS in a relatively short period of time and what the opportunities are for extending knowledge through research. So what is HS? HS is a chronic inflammatory skin condition that's characterized by nodules and abscesses that can go on to form tunnels and scars in intertriginous body sites. The course of HS is typically waxing and waning, and this is a disease that can be incredibly painful to the individuals affected. The most common age of onset for HS is in the second and third decades of life, and this is a disease that predominates in women and African Americans. And in fact, African Americans have HS rates that are threefold that of Caucasian people in the United States. The way that we typically think about HS severity is by using a staging system called the Hurley staging system that was developed by a plastic surgeon. And the way that HS is typically, most commonly staged is using the system. So stage 1, disease is characterized by nodules and abscesses, but no scar formation and no tunnel formation. Stage 2 disease is characterized by nodules and abscesses with tunnels and scarring. So even one tunnel will buy you a stage of 2 on this Hurley staging system. And then stage 3 disease is characterized by nodules and abscesses with multiple interconnected tunnels in any given body site. So one site that has this kind of presentation qualifies for stage 3 diagnosis. And this is a staging system, as I mentioned, developed by a plastic surgeon and was really meant to be used to guide the decision-making around surgical management of HS. But it is the simplest disease severity measurement tool out there, and now has kind of been adopted for making medical management decisions as well. So I'm going to show you here. This is a diagram from the North American HS management guidelines that were published last year. This is the first set of guidelines published in the US for management of HS. And you can see that across the top here, we have Hurley staging. On the left, medical therapies, physical therapies, and then management of acute lesions. And if you just follow this diagram down, this is meant to be kind of a tool to help guide management of HS if you know what Hurley stage your patient has. So patients who have stage 1 disease, these are folks that can be treated with topical antiseptics and antibiotics, hormonal treatments, occasionally retinoids. Stage 2 patients, these are typically patients who are on broad spectrum antibiotics, and this is when we're beginning to think about using biologics. These patients are also good candidates for smaller surgical procedures. And then early stage 3 patients, these are patients in whom we're treating with multiple different agents and modalities. So typically we're using both medical therapies and physical therapies to treat patients with stage 3 disease. So that is kind of just to make sure that we're on the same page, a broad kind of general background about HS. But to understand really why HS is neglected, we must first understand the historical context of HS in order to get a better sense of the problem at hand. So really for decades, due to under-recognition and misdiagnosis, we thought HS was a rare disease. It even had an orphan disease classification, which basically means that no specialty claimed HS as its own, and this really further contributed to its under-recognition. But recent epidemiologic data has suggested that HS is actually quite common, with a prevalence on par with that of other common skin diseases. And this graph shows HS prevalence to be around 1%, which is similar to estimates proposed for atopic dermatitis and psoriasis. And this common disease tremendously impairs quality of life for those affected by it. This is a graph of dermatology life quality index scores in various immune-mediated skin diseases, and the higher the score, the greater the impact of the disease on quality of life. And you can see the HS patients, which are shown here by early stage in red. The HS patient scores show that the more severe one's disease, the greater the impairment these patients face. And the quality of life impact in HS patients, as demonstrated by these scores, really, I think, is quite shocking when you compare it with other skin diseases that we know greatly impact quality of life. But despite these data on prevalence and morbidity, HS is understudied and it's underfunded. This graph here on the left shows publications per year for various immune-mediated skin diseases. And HS is this orangish line in the weeds at the bottom here, and there's some reason for optimism because that line seems to be on an upswing over the last 10 years. And we've seen more than 50% of all publications in the HS space has really occurred, cumulative publications, more than 50% of cumulative publications in the HS space has really occurred over the last 3 years. But you can see that we still have a lot of work to do and a lot of catching up to do to better understand HS. And on the right is a table of total NIH funds dedicated for HS-related research and total number of grants. Since this table was published in 2019, we've acquired 3 more NIH grants, but the numbers are, relatively the same. And you can see that grants and funds for HS have really paled in comparison to that of other immune-mediated skin diseases. And to really kind of put this in perspective, what we're talking about is just around $1 million in federal funding for HS-related research as compared with over $1.5 billion for psoriasis-related research. So there's a huge gap there when we think about funding and grants awarded for relatively equivalent diseases in terms of prevalence. And this dearth in funding in the federal space extends to the private space, the industry space as well. If we're specifically looking at completed clinical trials in HS, again, the numbers pale in comparison to that of other common inflammatory skin diseases with completed HS clinical trials rounding out in the low 20s. So really, it's no surprise then that given the lack of funding and the lack of trials, there really is only one single FDA-approved drug for HS. And perhaps it's a surprise that there's even one drug available at all, and that drug is adalimumab. And to be frank, that drug, although it is better than anything else that we've had to date, it's still not as effective as we'd like it to be for patients. And these data really clearly highlight that HS is a neglected disease, and that neglect is acutely felt by the people who are affected by it. HS patients, in addition to kind of being unseen and having all these issues with having all these issues in terms of kind of having their quality of life impacted, they also experience significant stigma related to their disease in multifaceted ways, including stigma due to their demographics, their race and their gender, as well as the nature of their disease, because it affects private body sites, it's malodorous, it's disfiguring, and also stigma due to modifiable risk factors associated with HS, including obesity and tobacco. And for all the kind of aforementioned reasons, these patients also experience significant barriers to accessing care. So we did this study with partners at Facebook, where we interviewed patient administrators of HS Facebook support groups, which at the time comprised over 80,000 HS patients, and now that number has grown tremendously. But we did the study to kind of better understand patients' experience of accessing and receiving care for HS. And what we heard again and again were a few common themes. First, they said that there seemed to be just a lack of knowledge about HS among healthcare providers. And I think one key quote around that theme is that they stated it's so rare to see a doctor who knows about HS. Another key theme that came up in those conversations was a lack of access to providers who did know about HS. They said getting in to see a dermatologist is like getting in to see the president. And then the third theme that we identified was a communication disconnect. They said doctors have problems with listening. They felt that doctors were dehumanizing them. And I think all of this kind of really can be nicely summarized in one statement, which is that distrust of doctors is rampant in the HS community. As a person who spends a lot of their time thinking about HS and taking care of HS patients, this was really heartbreaking to hear and to read and compile and put out there. But I think what I want to impress upon this group is that these are not unique sentiments in this patient community. This is something we hear again and again, and it makes it challenging to bring patients into modern medical care, and it also makes it really challenging when this is the sentiment that people living with this condition have about the medical and research community. It obviously makes it really challenging to conduct research and improve the care and improve treatments for these patients, because no animal models exist for HS. So structurally, how do we tackle this problem? We have a common disease. It's incredibly painful and impacts quality of life and ability to work and function as productive members of society, and patients with HS suffer tremendously. It's a disease that often goes unrecognized. Its clinical course in biology is not well understood, and the treatments that exist for it are limited. And all of these factors have led to a deep distrust of the medical community. So even as interest to help these individuals is increasing, patients are reluctant to partner with a community that's overlooked them for so long, which is understandable. So what I want to talk about today is just kind of this small problem, I guess. How do we, as dermatologists and as a specialty that owns this disease, how do we begin to talk about or think about tackling this problem of HS? So I want to start at the beginning and talk about the problem of diagnosis. And I'm going to try and get on gallery view here, and I want to ask you guys a question and see if I can get some responses by way of thumbs ups. How many of you are aware that diagnostic criteria exist for HS? I see you guys. You could chime in. Okay. So when I ask this question, in the majority of dermatology settings, there's usually kind of just a smattering of people that'll raise their hand. And this, I think, is a huge part of the problem. If we as dermatologists don't know that these criteria exist, you can bet that they aren't on the radar of other specialties that encounter these patients and have the opportunity to diagnose them. The diagnostic criteria for HS are quite simple. These are clinical criteria, and there are really three main criteria, and you have to have all three criteria to meet the diagnosis. Patients have to have typical lesions, so double-headed comedones, nodules, abscesses, or the tunnels and typical scarring that we see in HS. These lesions have to have a typical distribution, so intertriginous areas, the axilla, inframammary folds, groin, the anogenital region, these kind of the common sites associated with HS, and then the lesions need to be chronic. So the time frame that's been developed in these criteria is that these lesions must recur within a 6-month period. But you can imagine that if many people don't even know these diagnostic criteria exist, and people are not aware of the disease state, then there's going to be significant problems with diagnosis. And that is something that we see very commonly in HS. We conducted a study along with many other global partners who are interested in HS to try and understand the HS patient experience in terms of interacting with the medical community and getting diagnosis and treatment for their disease. And so over 1,000 patients across the world contributed to this survey study. And what we found was that over 60% of participants who reported that they had visited a physician for symptoms of HS 5 or more times prior to receiving their diagnosis. And we know from previous data that the median diagnostic delay for HS is around 7 to 10 years. So you can imagine for a moment what it must feel like to go into medical facilities and repeatedly with a painful condition for over a decade and not get a diagnosis. It's incredibly frustrating and in many cases quite devastating. And what we learned was that over half of the patients reported that they got their diagnosis from a dermatologist. So these data really kind of underlined for us that access to knowledgeable providers is key to timely diagnosis. And as an extension of that work, we wanted to understand some of the characteristics of HS encounters. So we used a big data set to kind of really understand what is happening in these encounters that HS patients are having with the healthcare community. And we found that 20% of HS encounters occurred with dermatology in HS, as compared with almost 50% of psoriasis encounters that occurred with dermatology. And almost 20% of HS patients overall received opiates, but the odds of receiving opiates for pain from dermatology was low, whereas the odds of receiving a non-antibiotic systemic prescription, which includes biologics, but also things like hormonal agents, those odds were quite high if they were seeing a dermatologist. So this really underscores that seeing knowledgeable providers is key to getting the appropriate treatment and impacting the trajectory of disease. But as we saw, the majority of HS patients really aren't seeing dermatology, and frankly, they don't have access to dermatology in many parts of this country. So we wanted to kind of better understand if these patients are seeing frontline providers for their HS, what kind of information are frontline providers getting in a regular way about HS, what kind of education and resources do they have access to. So we looked at HS publications in journals for frontline providers since the year 2000. And what we found was quite enlightening and frankly quite devastating. We found that since the year 2000, less than 3 HS publications were published annually in frontline specialties, and that accounted for less than 2% of all HS publications. So really, you know, we have a lot of work to do, both in terms of improving access for HS patients into dermatology and improving education for frontline providers around this disease so that we can make sure that the disease is being diagnosed in a timely manner and that patients are being referred in to see us for once first-line therapy has been administered for these patients and when therapy needs to be escalated. So the next area that I want to talk about, where there's an urgent need for the generation of new knowledge to advance the field and improve the care of patients with HS, is in our understanding of HS clinical course. So prospective clinical studies are needed to deepen our understanding of HS disease characteristics and clinical course in specific ways in terms of kind of identifying prognostic factors, understanding phenotypic heterogeneity that we see in HS, in order to understand the contribution of comorbidities to treatment choices and outcomes. We also need these kinds of data to assess long-term outcomes and assess the effectiveness and adverse effects of therapies in the real-world setting. And additionally, longitudinal data paired with translational studies can be used to uncover disease etiology, to develop biomarkers and predictors of treatment response, and to identify therapeutic targets that are necessary to guide the development of new therapies and improve the care of patients with HS. And so to that end, we created a national multi-center registry for HS called HS Progress, or HS Prospective Observational Registry and Biospecimen Repository. And the goals of this registry are really threefold. First, we are interested in methodologically characterizing and following a diverse cohort of HS patients. We're interested in collecting biospecimens along with this clinical data for translational studies. And of course, we want to partner with patients, and we want patients to feel empowered in this process, to share their story through survey completion, and also benefit from registry participation. So patients who are part of this registry are also consented at the time of consent to the registry. They're also able to consent to being contacted for therapeutic trials with novel agents, so they're kind of first in line for consideration for drugs coming down the pipeline. And it's really efforts like this that provide a unique data set that doesn't otherwise exist for HS, in which we can ask and answer novel questions about HS epidemiology that could impact care. And I want to just share one example of such a study. So we had observed that there was a small number of cases of HS patients who seemed to have a later age of disease onset, which previously had not been reported in the literature, in part because of this issue of diagnostic delay. If you're analyzing a claims data set, you have information on age of diagnosis, but you really don't have information on age of onset in this population because, as we know, diagnostic delay is significant in HS patients and in some cases can go on for a decade or more. So what we discovered in looking at a large number of patients in this data set in HS Progress, in whom we had patient-reported age of onset data, was that HS age of onset actually has a bimodal distribution similar to that which we see in psoriasis. And what we saw was that in that first peak of cases really occurs in the late teens, with women presenting slightly earlier than their male counterparts. And then there's a second peak of onset in the mid-40s with women and men presenting equivalently, kind of roughly equivalently in their mid-40s. And this study, I think, is an example of the power of these large prospective data sets for HS certainly, but also for really for any disease state. And HS Progress also presents some unique opportunities to really inform our understanding of disease progression and therapeutic outcomes in specific situations. For example, we know that HS is a disease that predominantly affects women of childbearing potential, but aside from really two papers that were recently published, one in JAMA Dermatology and the other in the British Journal of Dermatology, there's really very little data on the course of HS in pregnancy or pregnancy outcomes, and very little guidance on HS management in this setting. Similarly, the data on pediatric HS is sparse and is primarily at the level of case series and case reports. And although there's actually a lot of literature on the surgical management of HS, most of the studies in the surgical literature are of kind of variable quality for a variety of reasons, including use of retrospective data, and there really is, frankly, at this point, no uniform definition for remission or recurrence in HS, so the data are quite jumbled. And what we've tried to do is to use HS Progress to systematically collect data on HS patients, certainly more broadly, but also in these specific groups across the country, so that we can begin to kind of better answer questions that pertain to patients that fall in these categories. So, and we've also leveraged our experience with registry development to develop the global Hidradenitis Suppurativa COVID-19 registry. The goal of this registry is really to understand the risks, the clinical course, and the outcomes of COVID-19 in HS. And the rationale for doing this is multifold, really. We know that although patients who seem to have the most trouble with severe COVID-19 illness tends to be the older or elderly patient population, and HS patients are quite young. HS patients do have significant comorbidities, including obesity and diabetes, and there's even some new literature showing that HS patients are likely have an associated chronic pulmonary conditions, and all of these kind of comorbidities potentially portend a greater risk for severe COVID illness in these patients. Many HS patients, and certainly those who have more moderate to severe disease, are on biologics, and we don't really understand in this patient population what the effect of biologics will be on their COVID illness. And then, of course, what we have been talking about for months now, and really critically important issue that's reached a fever pitch now is health disparities. And the patient population that is affected most significantly by HS falls squarely in the group of patients that experience tremendous disparities in healthcare access and treatment. So we want to kind of better understand how that affects clinical course and outcomes in this patient population as well. So for those of you who encounter HS patients who are COVID-19 positive or suspected to have had COVID-19 illness, please consider visiting our website and documenting that case in the registry. The third area that I'd like to talk about today, where there's a gap in knowledge that's limiting our ability to improve the care of patients with HS, is in our understanding of HS biology. We really have, unfortunately, a rudimentary understanding of HS mechanisms. We think that this is a disease of follicular occlusion, which leads to the rupture and dermal seeding of bacteria and cellular debris, and this leads to the influx of inflammatory cells and mediators into the skin that is responsible for this robust inflammatory response that we see clinically in HS. But really, it's unclear to us if follicular occlusion is the primary event or a secondary event, and we also really don't yet know what the role of bacteria is in HS, although we do know that they have a role because we know that HS is responsive to antibiotic therapy in many cases, even when that is short-lived. Until relatively recently, the studies that focused on understanding the role of bacteria in HS focused on culture-based methods to identify organisms. And in total, across all of those studies, about 50% of lesional specimens were culture negative, and of the culture positive lesional specimens, what we predominantly were able to grow out of these cultures was coag-negative staph and mixed anaerobic bacteria, and then followed by kind of Staph aureus, shown here in royal blue on the pie chart, and Corynebacterium species, shown in light blue. And these findings have largely guided the use of antibiotics that we're all familiar with for the management of HS, including tetracyclines, clindamycin and rifampin, aminopenicillins, and fluoroquinolones. And although, as I said, antibiotics might be helpful for the management of a subset of HS patients, these effects are often short-lived. So once the antibiotics are stopped, patients do tend to flare. With the advent of the human microbiome projects and studies that have demonstrated a role for microbial alterations in the pathogenesis of inflammatory skin diseases like inflammatory bowel disease and psoriasis, these are diseases that are related to HS, there's been really a growing interest to use culture-free sequencing methods to more deeply understand the role of bacteria and microbiota more broadly in HS, to understand how to leverage microbial therapeutics to treat HS. And that is some of the work that we have been doing. Our group and others have shown that there's a decreased relative abundance of skin commensal bacteria and an increased relative abundance of mixed anaerobic bacteria at HS lesional sites as compared with controls. And we've been able to leverage the biospecimens and the clinical metadata that we've collected through HS Progress to get a better understanding of how HS microbiota perturbations differ with disease severity. So this is a principal coordinates plot, which kind of very broadly shows how alike or how different skin microbiota of each specimen is. So each symbol on this plot corresponds with one inguinal crease specimen. The symbols that are red correspond with HS patients. Those that are blue correspond with healthy volunteers. And depending on what shape the symbol is, that really designates the Hurley score for those patients. And what we see here is that bacterial communities from adults with mild HS cluster tightly with healthy volunteers, indicating that they have higher similarity between skin bacterial communities in these subjects. And the bacterial communities of adults with moderate and severe HS overall, so Hurley stage 2 and Hurley stage 3, cluster separately from mild HS and healthy volunteers, with severe HS separating further from mild HS and healthy volunteers than moderate HS. And we wanted to kind of better understand what was driving the differences we were seeing across disease severity. So we looked at the relative abundances of individual bacterial taxa by Hurley staging and found that the separation of samples by disease severity moderately positively correlated with relative abundances of mixed anaerobes and negatively correlated with relative abundances of major skin commensals, including commensal staph species and Cutibacterium and Corynebacterium species. And these findings kind of overall really suggest that skin bacterial communities in HS are not only distinct and diverse, but they're also divergent from those of healthy volunteers, and that worsening HS disease severity is associated with increasing skin bacterial perturbations in HS and higher within group variation in more severe HS. So what we're now kind of in the process of understanding is how these microbial perturbations wax and wane over the course of HS clinical disease, and what that interplay is between those perturbations and those fluctuations and cutaneous immunity, and how microbial products tickle the immune system to react with the inflammatory response that we see in HS. With all this kind of epidemiologic data, and now kind of moving into more mechanistic data and trying to understand HS biology, federal agencies have understood the need for a generation of new knowledge in HS and really begun to support this work with the leadership of Ricardo Sabati at NIAMS and the late Steve Katz, including a lot of the work that I've just discussed. So I'd really be remiss if I didn't mention the funding opportunities that have been created in this space. There's an R21 and R01 mechanism that has program announcements that have been put out by NIAMS, and these are the first disease-specific PAs that NIAMS has ever put out. So it's really, so I really want to encourage folks who are interested in HS-related research to take advantage of these funding mechanisms. We're really not sure how much longer they'll be around, although we're quite hopeful. But these are great opportunities for folks interested in this space. The last area that I'm going to touch upon today, where there's an urgent need for generation of new knowledge, is in the treatment of HS. As I mentioned earlier, there's just one FDA-approved treatment for HS, and that is adalimumab. And while having some treatment option is certainly better than having no treatment options, adalimumab is really not uniformly effective for HS. In phase 3 trials published in the New England Journal of Medicine, this was a pair of phase 3 trials that were reported in one paper. Around 50% of patients demonstrated a response to weekly dosing with adalimumab, so at 40 milligrams, at the 40 milligram dose. But the response was really defined by a novel measurement tool called the HI score, which is defined by 50% reduction in the abscess and nodule count with no increase in draining tunnels. So response in these trials was not complete response, but it was just, half of what patients kind of started with. And you can imagine that while reducing your painful lesions by 50% is certainly an improvement, it is by no means kind of the cure or the slam dunk treatment that we're looking for these patients. And while it may improve quality of life, patients with this, with HS on these treatments, they still suffer tremendously. And that is, these results in clinical trials have been borne out in real world clinical practice as well. So there is a need for better treatments for HS, and there are a lot of novel targeted agents coming down the pipeline for HS. So this is something that we're all going to hear a lot more about in the coming years. These are just naming a few, but I think there are a couple more even in addition to this that are that we'll see in the coming years. So there certainly is kind of this need for new treatments, new disease targets, but as I've kind of alluded to, having access to promising agents to test is also really not enough. You have to know what to measure with HS, and you have to measure something that's both clinically meaningful and also meaningful to patients. And the outcome measurement tools that we've developed for HS, they really don't meet this mark yet. We've developed over 30 tools, 30 different clinical measurement tools for HS, and they're flawed in various ways. And the HI score, which is the tool that was used in the adalimumab trials that I just showed you, and which is a tool that you'll probably see in almost every HS clinical trial coming out today, doesn't necessarily measure meaningful response in disease or in patient expectation of improvement. And this is really, and this tool has really been shown to artificially elevate placebo response and has led to this spectacular failure, most recently of a first-in-class monoclonal anti-human complement factor C5a antibody that held great promise for HS. So getting good drugs approved into the market requires better outcome measures, and the development of tools has really been the focus of this group called Historic, which is part of the International Dermatology Outcome Measures effort that's been led by Alice Gottlieb over the last several years. And this group, Historic, is really a group of investigators, industry partners, patients, and the FDA that is developing investigator and patient outcome measures for HS. And this effort really has gone a long way in building bridges with HS patients. And we hope to have some novel outcome measures ready and in trials this year, and the opportunity to validate those outcome measures over the coming years. So today, this is what we've talked about. We've learned kind of what HS is and made sure that we were all on the same page. We talked about some data that supports HS as a neglected disease. And then we've talked about what work has been done in this space really over the last decade primarily, and where there are opportunities to grow that knowledge. And for all young investigators out there, the burgeoning investigators, if you're interested in making an impact in our field, and you're looking to take care of patients who really suffer, I really encourage you to take a closer look at HS. There's so much work to do in this space, and there's a lot of opportunity for professional development that's incredibly gratifying, and I'm happy to talk with anyone offline about that. And then, of course, I have many, many, many people to thank for a lot of the work that I showed you here today, and I'm happy, delighted to take any questions. Thank you.
Thank you very much, Haley. One of the many drawbacks of Zoom is that you can't hear the audience applauding.
Thanks.
But I know our audience is, and that was a great talk. It's particularly inspiring to see the whole spectrum of a disease advocate who tackles not only the epidemiology and the outcomes and the clinical effects and the psychosocial impacts, but then gets into the fundamentals of the therapeutics and highlighting the needs for funding and all the different parts that it takes to make research successful and make an impact. And you did a great job of just tagging each of those things. It's not that often that I see a talk that does that many different things. And I don't think I've ever seen anybody also recognize the NIH funding opportunities and initiatives beyond saying thanks for the dough.
Well, I do thank them for the dough.
Yeah, that too, of course. But that was a great job.
Thank you.
We have some clapping on the chat, and I think there's a question from one of our residents talking about reading your microbiome paper in the JID.
Yeah.
And he was wondering what your thoughts are regarding the use of doxycycline, since it doesn't cover anaerobes. So
yeah.
I'm sure
thanks, Kevin, for that question. So we know doxycycline, I'd say, is probably anecdotally the most frequently used agent for treatment of HS. Based on the data that I've put out there, you can imagine that I'm not thrilled to use that monotherapy for HS management, but I think we still have a lot to learn, right? Because people use doxycycline because it works. And if it didn't work, then people would stop using it. So I I wouldn't be so pompous to say that I fully understand the role of gram-positive bacteria in HS. I think there is just so much more work to do in my own clinical practice. I rarely use doxycycline monotherapy for management of HS.
Yeah, certainly we have used doxycycline probably more effectively for the papular pustular phenotype in
Sure.
rosacea, and it appears, much of its efficacy may be related to its metalloproteinase inhibitor activity rather than any activity on inhibiting bacteria. So, a lot of these antibiotics have off antibiotic effects, and maybe that's why it helps. But I guess in the VA population I see, I'm not too impressed with doxy as being very effective for the HS patients.
Yeah. Yes, I am speaking to an expert after all. Thanks for that insight.
Let's see. George Hightower is asking Paul if you could make him a panel so he can say something. Yeah, great. Go.
Can you hear me all right?
Can hear you, George.
All right. I just wanted to say thank you for a great talk. I mean, that was both informational, also inspiring. Some of the folks know here that I've taken an interest in HS and PEDS. We definitely see it in PEDS, and I think it's underappreciated and undertreated disorder. I think one of my interests in kind of waiting for the research is, what can you say about the genetics? We definitely see multiple family members affected. I think maybe it's here in San Diego that we see disproportionate number of folks of Mexican ancestry or Latino. So I see high numbers in those communities in addition to African Americans.
Yeah, so this is a great question, and I'll start by just saying we're so far behind. There are a couple groups in the US that are very interested in understanding the genetics of HS, Wilson Liao at UCSF, and the group at Columbia. I think they were just funded to do this research, actually, in a third group at UNC Chapel Hill. So I think we'll have more information forthcoming, but really we know very little right now about the genetics of HS. As somebody who takes care of HS patients, it's in my practice very common to see families with HS, but surprisingly, the literature that exists suggests that HS is not a heritable disease, and I personally don't believe that.
Yeah, there's a question in the chat from one of our residents, Ogechi, who is really bringing up the question of the BMI association. Clearly, that's a major modifier in the appearance of the disease. What about the therapeutic response?
Yeah, hi Ogechi. Ogechi and I know each other because she was at UCSF when I joined faculty. So what we know is that there's definitely differences in kind of the way we need to treat these patients with normal BMI versus higher BMI, or that falls in the obese and morbidly obese ranges, including dosing effects. So one of the issues with adalimumab is that the drug is only approved for a single dose at 40 milligrams weekly. And we know that for our obese patients, this dosing is often not enough. So we are trying to take the approach that our colleagues in gastroenterology and other specialties have taken, where we're looking at serum adalimumab levels to better dose patients, more appropriately dose patients. We also, to answer Ogechi's question in a different way, we know that HS patients who are thin or underweight even are patients that tend to have kind of more severe disease and tend to be more likely male. And that variant of disease can be really refractory and quite challenging to take care of. And the biologics and other treatments that we have today are not really meeting the mark for those patients. So part of what we're hoping to do with HS Progress is subset these clinical phenotypes and try and better understand the biology of this heterogeneous disease. Thanks for that question.
Any other questions from the audience? You can see by chat. Things like smoking are also can be associated with changes in the microbial community. Any speculations on the association of smoking and HS?
So that's work that we're actively trying to do. I mean, you know, Rich, part of the issue with HS is that there for many years was not even any baseline knowledge. So we've worked pretty hard to just create like the ground level information in this space, but we're now starting to collect microbiome samples from patients who are smokers and not smokers, people who are on therapy and not on specific therapies, and trying to understand how the microbiota are affected. But as yet, we don't have that data available. I see a question about laser hair removal in the chat that I thought I might address. So, you know, for years, laser hair removal treatment for HS was really hard to get approved. And then part of the reason why we wanted to have these North American HS guidelines published was to have one document that providers could use with insurance companies and to support their therapies. And since the publication of those guidelines, I personally, and I know many of my colleagues around the country, have had much better success getting laser hair removal approved for the management of HS. I think it's most helpful for people who have more mild disease. And frankly, I think that's actually, in some ways, I mean, the challenges are different, but the challenges of treating patients with more mild HS, I think is we don't have many therapies for that group. Are we going to keep those people on oral antibiotics indefinitely? That doesn't make any sense. Not everybody is a candidate for hormonal treatments, and certainly young men are not interested in being on spironolactone with all the side effects associated with it. And this is kind of a subset of HS that I think laser hair removal works nicely for.
Yeah. Okay, well, I thank you again. That was a great talk. I believe Paula got your permission to record your lecture. Is that correct?
That's right, yeah.
So we have been recording this. Paula, you could turn it off, but it's we will post the recording on our website for people